Hello and welcome to the webinar. My name is Megan Nicholson and I am the Director of Marketing at wellbe.me. We're happy you've decided to join us today for patients, pain, and their perceptions. Powerful techniques to help patients manage pain before, during, and after hospitalization. A few housekeeping details before we get started. This webinar is being recorded and you should receive a link to the recording and slides tomorrow by email. Please feel free to share this webinar with colleagues who could not attend today. The question and answer session will immediately follow the presentation. If you have a question for our speaker, please type it into the questions box in your GoToWebinar panel on the right side of your screen. Today's webinar is sponsored by Wellbe's Guided CarePath. A guided care path helps set proper expectations for surgery, including pain management information, by creating a continuum of connections between patients, their family, and their providers. Smart checklists deliver just in time as patients progress through their surgery plans and recovery. The information is always there for reference when needed in case preparation or follow-up instructions are forgotten. This helps reduce patient anxiety and improves outcomes. To request a free demonstration, visit us at wellbe.me. Now I'd like to introduce our speaker for today. Edward Lee is the founder and director of the Center for Healthcare Communication. He and his colleagues focus on creating high-performing healthcare environments, primarily focusing on effective communication between colleagues and with patients. He presents high-energy and informative programs for hospitals, healthcare associations, medical practices, long-term care facilities, government organizations, and universities. He has a master's degree in health education and recently completed the soon-to-be-published book, Engaging Your Patients. His expertise put him in the national spotlight through interviews on The Today Show, MSNBC News, the Discovery Channel, and the Oprah Winfrey Network. He has been interviewed by Katie Couric and Montel Williams. Edward, at this point, I'm going to hand you the controls, and you can take it away.
Thank you, and welcome everyone to Patients, Pain, and Their Perceptions. Hopefully you'll see on the screen the intro slide. But before we get started, I just wanted to briefly mention a few details about terms I'll be using just very quickly. Of course, patient. Yes?
You'll need to click the Show My Screen button again, because I...
Oh, okay. I lost that. Show My Screen.
If you expand your webinar panel, there should be a play button there you can push.
Okay, so what do I click here? Oh, show my screen.
Yep.
Okay, so now, how am I doing now?
We see it. It looks good. Thanks.
Okay, great, great. And once again, just briefly mentioning the terms I will be using. Patient, of course, is the person we're taking care of. Professional is any professional, doctor, nurse, physician assistant, technician, anyone that is a professional that works with the patient. And the last term is caregiver, and in this case, I'm using the term caregiver to describe a family or friend. That is the caregiver in this case. And the reason I mention that because a lot of medical organizations use the term caregiver to describe professionals, which I think is great, but when I discuss caregivers, I'll be talking about family members or friends. So to avoid any confusion, caregiver in this context means family member or friend. Let's look at our program objectives. Okay, there we go. Our program objectives. We're going to be talking about surefire methods of communicating with patients through the continuum of care, pre-hospitalization, inpatient, post-hospitalization. We're going to talk about how to improve your bottom line because HCAP scores, patient satisfaction scores, tie into reimbursement, so the better pain is managed, the higher the scores, the higher your revenues. We're going to talk about how to avoid patients from becoming angry, but if they do become angry, I'll have some tips to handle with that. We'll talk about reworking the commonly used 1 to 10 pain scale, and we'll be discussing non-pharmaceutical methods of pain management. Now, what I just did at this point is actually an excellent communication skills tool that I recommend all of us use. It's called signposting. When you go on the street and you see a post, there'll be a sign on it, and that will have a street name. What that does, it gives us direction. And we could use signposting to give patients direction. For example, you're sitting down with a patient and you're discussing pain management related topics and their needs. you would say, first we're going to discuss this, this, and this. So you're telling them what they're going to be experiencing. For example, signposting could be used in the emergency department, telling a patient it's going to take about an hour for this procedure, it's going to take about a half hour for this, and the physician wants to admit you, and you'll be admitted within X number of hours. So it relieves a lot of anxiety when you tell patients what's coming next, providing an overview, agenda. Well, before we actually get into anything about pain management, we're going to be talking about some psychosocial factors. Now, you're probably thinking to yourself, wait a minute, I came here to talk about pain management, and this guy's talking about psychosocial factors. The reason I'm talking about psychosocial factors is I have interviewed thousands of patients in person, on the phone, through email, through message boards, and what they all tell me, this is a common theme, is I want to feel a sense of connection with my healthcare professional. I want to feel a sense of trust. I want to feel a sense of caring before I'm going to listen to their advice. So you could have wonderful pain management materials that are jargon-free, that are well-designed, but unless there's a connection with the patient, it might not work. They might not take your advice. And it makes sense on an intuitive level. Say you have two friends, one you feel a connection with, one you don't, and they both give you advice. You're more likely to follow the advice of the person you feel a connection with. A wonderful patient advocate named Riva Greenberg, she came up with a slogan that I love: rapport before report. Establish a sense of connection with patients before you move on to the information, because we connect with each other through emotion, not information. For example, I'm sure you've seen many TV shows where they talk about different disease entities, and they usually have a clinician talking about the clinical aspects. That's the information. Then they have a patient sharing their story, and when audience members hear the story, they say, oh, wow, that was so moving. Oh, gosh, so that patient's story really made the difference, because we connect with each other through information, or emotion, rather, not information. Just some quick tips on how to increase our level of rapport is empathize before you educate, similar to the rapport before report. And I do believe all of us have empathy in our heart, but patients aren't mind readers. They need to hear it. And what I recommend is when you're talking to patients, do a quick empathic statement. For example, you could say, it sounds like you're going through a lot of stress right now. It sounds like things have been very difficult for you now. And we get so caught up in all the medical aspects, sometimes we forget the empathy part. For example, I worked with one physician. There was a patient who came in. He was an elderly gentleman, multiple health issues, and we were talking about his medications. And at one point he got choked up and teary-eyed, and he said, 2 months ago my wife passed away and she handled all of this. It's been very difficult. And the physician was really very pleasant, just went on to the next question. So do you remember if you took this med or that med? And she was wonderful, but she completely missed the emotional dimension. So when I spoke to her afterwards, I said, there needed to be some empathy there. It sounds like you're going through a rough time now. I can understand how difficult this must be for you, and I just need to ask you a few more questions. And that empathy makes a big difference. Also, one other quick thing to increase the psychosocial part of our interaction with patients is to mention some things about their personal life. For example, if you're a patient, you're in the process of admitting and you're discussing pain management, and they happen to mention that their daughter is getting married in a few months, say, oh, congratulations, how exciting for you. I'm so thrilled for you. And that helps make the connection, because remember, we connect with each other through emotion, not information. One quick story, the physician left me a voicemail message about a month ago. He says, you saved me $70. Call me back. I'll explain. I coached him about a year ago. He's a hospitalist, and he said, since I've been asking briefly about these personal stories, I've just seen incredible changes in my interactions with patients. I was talking to a patient, and he was being discharged. I was planning for his discharge, and he said, so what are you doing the rest of the day, Doc? And I said that I'm going to be done here about 5, and then I'm going to get some flowers for my wife. He said, don't worry about the flowers. I'll take care of the flowers. You have been so wonderful. That's the least I could do. My daughter's coming to pick me up in a few hours. She owns a florist shop. I'll have her put together the most beautiful floral display you've ever seen. And he said he's never experienced these things in his 20-plus years of practicing. So these little personal things make a big, big difference, and they only take a moment, only take a moment. Well, let's talk about something we want to avoid, a Shirley MacLaine meltdown. For those of you that have seen the film Terms of Endearment, there was one point where Shirley MacLaine and her daughter, played by Deborah Winger, have an issue in the hospital. Without giving away the whole plot, they have a very tempestuous relationship, so to speak, and the daughter in the film, Deborah Winger, became very sick with cancer, actually terminally ill. And at one point in the film, her daughter needed her pain shot. It was 8 o'clock, so Shirley MacLaine politely went to the nursing station. It's 8 o'clock. My daughter needs your pain shot. And they said, we'll be with you in just a moment. So she goes to the next nurse. It's 8 o'clock. Now it's actually after 8 o'clock. My daughter needs her pain shot. She's in pain. We'll be with you in just a minute. She goes to the third nurse. Same kind of response. Finally, she just shrieks, give my daughter the shot. And she screams out. And, of course, they run to give her the shot. Once you have a patient escalated to that kind of event, the HCAP scores are pretty much not in good shape. Once you've reached that point, the HCAP scores for that pain question are pretty much toast. So what we're going to talk about is to avoid a Shirley MacLaine meltdown. So now if we look at the next slide, we'll be talking about HCAPs. And what HCAPs are, that's a patient satisfaction survey through the Centers for Medicaid and Medicare. Here's a statistic for the period of October 1st, 2011 to September 30th, 2012. 71% of hospitalized patients responded with the response of always to this composite question, how often was your pain well controlled? Well, if 71% said it was always well controlled, roughly a third of the people do not feel their pain was well controlled. And a lot of the problem is, in terms of the perception, a lot of people feel that well controlled means no pain. But of course we know that we're talking about controlled pain. Even with the best pain medications, patients may still have some mild pain, and it's important that patients understand they may have some mild pain, some residual pain, but we have to be careful that we don't overdose them. And so it's very important to explain the difference between pain management and pain elimination. And I've talked to a lot of patients who gave low scores on that question because they had some mild pain and they thought, well, I have a little pain. They didn't manage it well. So it's very important that patients understand the difference between pain elimination and pain management. And that's when the pre-hospitalization discussions are extremely important, and that is our next slide. Pre-hospitalization pain management. It's very critical that this part goes very well because we need to explain to them what to expect. And it's very important that we plan for this. One of my favorite quotes is, people don't plan to fail, they fail to plan. So during this process, we need to begin the discussion. And I always recommend saying to patients, we will do everything possible to make sure you are as comfortable as possible. It's important that we use these terms, everything possible, comfortable as possible. That's very important. And as I mentioned before, it's very important that patients understand that we're going to keep them as comfortable as possible, but they still may experience some mild pain, and then we'll talk about some other ways to handle that. But it's very important that they may have some very mild pain, but we have to balance that out with their safety, that we don't give them too much medication. So once again, this discussion is very important because if we don't have this discussion, we could run into Shirley MacLaine moments. And of course, the last thing is provide written information. However, I recommend just do not hand them a brochure because we know a lot of patients don't read the brochures. So what I recommend is just opening it up and briefly going through it. And I also recommend having a highlighter or a pen to highlight certain areas. These are the most critical things you need to know because we know what's most important, but they don't know what's most important. So just open up that brochure, highlight a few things to make sure that they really get it. Now we've talked about pre-hospitalization. Let's talk about once they're in the hospital, inpatient pain management. And I recommend these two questions, that every question should be asked in the admitting process. Every patient in every hospital in the world, I believe, should be asked these two questions. What could we do to make this the best possible experience for you? And what are your concerns? Once again, what could we do to make this the best possible experience? And what are your concerns? So up front, we know all their hot button issues. We know all their issues. We know what we need to address with this patient. And in terms of patient satisfaction, in terms of pain management, the responses to these two questions are dramatic. I've heard about hospitals incorporating these two questions, and their patient satisfaction scores went up through the roof. And it's interesting, staff satisfaction went through the roof. It's just two great questions that I recommend you incorporate. Just a few quick things since we're talking about communication. I have to mention this clinician appears to be a physician, but I'm not sure. This clinician is doing a lot of wonderful things. First of all, he's at the patient's eye level. He's obviously sitting, and I always recommend sitting. If you're going to be spending even 5 minutes with a patient, sit. Because when we sit, it sends the message, I have time for you. Also notice they're shoulder to shoulder. In the speaking biz, we call that squaring up. Excellent tool of nonverbal communication. And the last thing is, notice the clinician is leaning forward. Leaning forward shows interest. Leaning forward is an excellent communication tool. Leaning back indicates that we're not very interested. Like I always think of the expression, like we're just kicking back. So no, we want to lean forward. That is the ideal position for showing people that we're interested in what they have to say. Well, typically in organizations we talk about the 1 to 10 scale, and I do have some concerns about the 1 to 10 scale because it lacks clarity. For example, say you said to a patient, okay, on a scale of 1 to 10, 10 being the worst, how would you describe your pain? And let's say they say a 4. Well, what does a 4 really mean? What does a 4 mean to them? What does a 4 mean to you? What is your definition of a 4? What's their definition of a 4? So it gets very cloudy. There's no clarity in terms of what those numbers actually mean. And I have seen organizations use a chart that has smiley faces, like 0 would have a great big smile, and the smile starts to decrease, and then you start getting frowns. But once again, a half smile, what exactly does that mean? What does that mean to you? What does that mean to the patient? There's a lack of clarity. You and the patient are not on the same page. So I recommend a slightly more detailed assessment of that 0 to 10 scale, and that's our next slide. I found a great source. I have the link there, a PDF. It's through Stanford University, and they do an excellent job in terms of clarity with the 0 to 10 pain scale. For example, and we'll go through each section. There's 3 slides. 0, of course, is you're feeling completely normal. There's no pain at all. 1, 2, and 3 are described as minor. It does not interfere with most activities. So very mild could be just barely noticeable, like a mosquito bite. 2, there's discomfort. A minor pain, like when you've pinched your skin, like I'm doing right now, it's a little discomforting. Number 3, tolerable. It's a noticeable pain, like an accidental cut, but it's still manageable. So what I recommend is putting together one sheet. I've seen organizations, hospitals laminate it, and you just show it to the patients, and you're thinking, oh my God, this is going to take so much time. We don't have this kind of time. But it only takes a moment. They just look at it. They find a word that, oh, yes, that's it. So you know exactly what they're talking about. You understand what a 3 is. They understand what a 3 is. Let's look at some other words here, or other pain scale numbers here. Moderate. This is 4, 5, and 6. This is moderate. 4 is distressing, a strong, deep pain like a toothache or stubbing your toe very hard. I remember this past August I developed an unpleasant ear infection, and I went to see my healthcare team, and one of the nurses very politely said to me, well, on a scale of 1 to 10, how would you describe the pain? I said it's a 4 because it's distressing. It's a strong, deep pain like a toothache. It's in the moderate range. And she looked at me and said, okay. And then I explained to her why I said all of that, and then I mentioned how helpful it is to have a scale so everyone is on the same page. Number 5, just very briefly, is very distressing. It's a strong, deep, piercing pain, such as a sprained ankle when you stand on it the wrong way, or it's mild back pain. 6 is strong, deep, intense, piercing pain. It dominates the senses and causes you to think somewhat unclearly. The next slide is severe. This is very significant pain. 7, very intense. 7 is similar to 6, except you're not thinking clearly about half the time. 8, utterly horrible. Pain is so intense you cannot think clearly. 9, excruciating, unbearable. Pain is so intense you cannot tolerate. And finally, 10 is unimaginable, unspeakable. pain so intense you will go unconscious shortly. So, once again, hopefully most people have never experienced this kind of pain, and it's also something that's not very clear about the 1 to 10 scale. Does 10 mean the worst pain that that patient ever experienced, or the worst pain that anyone could ever experience? And I've heard people say both, 10 being the worst pain anyone could experience, or 10 being the worst pain you've ever experienced. So once again, this provides a lot of clarity, and that's why I recommend potentially laminating a sheet. You could potentially even have just one word for each number, just so when a patient says a number, you both know what the number is. And when you don't do any kind of sheet, when you just ask a patient to say 1 to 10, I've had patients who were, they were smiling, and they were experiencing pain, and I said, well, on a scale of 1 to 10, and they said a 10. I said, a 10? I said, are you sure? Oh, yes. Oh, yes, a 10. And then I explained to them what a 10 meant, and this was before I had the sheet in front of me, and they said, oh, I realize I'm not experiencing a 10. It's probably really more like a 4. But that's, once again, why this is so important, that you gain clarity, that you're both on the same page, you both understand exactly what is happening over here. And once again, it just takes a moment to put this on a sheet, have, say, a single word, show them the sheet, and so this way you could both say, oh, yes, this is definitely a 4. I could do this, but I can't do this. And then as you're working with patients on their pain management goals, say they've had surgery, and now you're working on what's coming next, you could look at it, okay, now yesterday you said you were a 5. How about today? Today maybe you're a 3 or a 4. So this way you're always on the same page, because it's always about clarity. That's the critical tool. It's always about clarity. And once again, you could easily laminate these sheets and have them available. And one other thing, if you do have the laminated sheets, make sure they're actually used. I've consulted with hospitals where they did have the laminated sheets and they still did the verbal thing. On a scale of 1 to 10, what's your pain? And the person says a 5, but what's a 5 if you don't have the sheet? So it's all about clarity. Okay, I think we've gone through that well, and you've got my point about why clarity is important on the 1 to 10 scales. Let's look at our next slide. Some other things about inpatient pain management. During shift reports, during shift changes, we want to make sure that we clearly communicate with our colleagues during the shift change about the patient's pain management. I especially like the bedside shift reporting, because I find that very helpful to incorporate the patient in the discussion. Of course, when you do bedside shift reporting, you have to be careful about jargon. When we're speaking to each other healthcare professionals, we know the jargon, but a patient might not know the jargon, and it might sound very frightening to them when they hear certain words. So when doing bedside reporting, be very careful of the jargon. And speaking of issues, jargon tends to be, of course, one of my hot-button issues. We need to use everyday language, and sometimes we get so busy because we talk to each other using jargon. When we go to professional meetings, we use jargon. Literature, it's jargon, but we need to turn it off when we're talking to patients. For example, there was one patient I remember reading about. She complained that to the ombudsman at her hospital that the doctor called her an idiot, and they knew that he would never have called her an idiot. But actually what he did is he used the term idiopathic, and that caused a problem, and she thought the word was idiot. And then in one of my workshops, a nurse mentioned that a patient complained to the administrators that one of the nurses called her fat. The nurse did not call her fat. What had happened is, in their hospital, they use computers on wheels, cows, and she used the term cow, and the patient thought that cow was referring to this patient, but she was actually referring to computer on wheels. So I recommend actually using the word wow instead of cow. Sounds better. Next, hourly rounding. Once again, I wanted to mention the term is hourly rounding, not hourly hellos. Once again, in some of the organizations I've worked with, people do come in every hour and they sign off that they were there, but it's really more like a quick, hey, how are you doing? And then they're out the door. Now, of course, I know you don't have all the time in the world, but it needs to be a little more detailed than that, checking in with people, checking on their pain, checking on comfort levels, see if they have to go to the restroom. So it has to be a little more detailed than a quick, hello, how are you doing, and then out the door. Also, one thing I recommend is I recommend hourly rounding, but I do not recommend calling it hourly rounding to patients. Rounding is jargon. That's one of our words. It's not a patient word. Some patients may get it. I talked to one patient when she heard the term hourly rounding. She thought that meant, oh, isn't that like that grand round thing when all the physicians come in? And I'm so excited that every hour all the physicians are going to come in and see me. So I had to explain to her what hourly rounding really meant. So instead of saying to a patient when I first admitted, we do hourly rounding here, say, someone will check on you every hour, rather than rounding, because they might have no idea what rounding means. And once again, during this hourly rounding, we want to always emphasize we're doing everything we can to make you as comfortable as we can. And it decreases patient stress knowing that you're checking on him or her every hour. And also, during this hourly rounding, we could discuss the next dose of pain medication to prepare the patient so they're not wondering when their next dose is coming. I highly recommend using a whiteboard to keep track of patient pain meds, to keep track of when the next dose is. And of course, we want to celebrate the victories as the patient experiences less and less pain, like maybe they came in as a 6, and then the day after that they were a 5, and now they're getting into the 3 range. So that's a reason to celebrate. Speaking of those whiteboards, let's look at a whiteboard. And I think these are great, by the way. I absolutely recommend having these whiteboards where you list my pain medication, you list the pain medication, the last dose given, and then you mention, of course, when that is, and then you mention when the next dose is going to be administered. Now, having this information readily available to patients and family members reassures them that you are doing everything possible to manage their pain. Once again, doing everything possible to manage their pain. Now, one critical point I want to mention about the whiteboards is a lot of organizations use the whiteboards. I recommend everyone does. They're an excellent tool. But there's a problem with the whiteboard, and this is the problem. They're up on the wall, but they're not being discussed. And we just assume, oh, the patient's going to look at it, but they might not look at it because, you know, they're probably not, obviously they're not feeling well. They're under stress. Being in the hospital, people under stress. This is not their natural environment. So make sure that you actually refer to the whiteboard. So what I recommend is, let's just review. Okay, this is your pain medication. This is when your last dose is given, and this is when your next dose is going to be given, and that will be coming up shortly. Just remind people because, you know, once again, they're under stress. This is not their natural environment. Also remind family members, too. It's very critical that family members understand this. And when it comes to patient satisfaction, family members are very, very important. Because when that survey, let's say it comes in the mail, is the patient actually filling it out? Is a family member filling it out? Is a friend filling it out? So we have to make sure not only does the patient have a great experience, we have to make sure the family members are also having an excellent experience, because the family member may be the one filling out those surveys, especially if you're dealing with a patient who has some kind of cognitive impairment, some type of dementia or stroke that causes a cognitive impairment. The survey may be completely filled out by a family member. Next, avoiding angry patients, because once again, we want to avoid a Shirley MacLaine meltdown. We don't want that happening, because once the anger gets to that level, it's very difficult to deal with and resolve. So we want to do whatever we can to avoid a Shirley MacLaine terms of endearment meltdown. One of the ways we could do that is to make sure we have discussions early on, before the person is hospitalized, during the admitting phase, discussing their perceptions, discussing their issues, asking questions like, what could we do to make this the best possible experience? What are your concerns? Mentioning all these things up front. And once again, discussing controlled pain, discussing exactly what that means, emphasizing that they may have some residual pain. Controlled pain doesn't mean an absence of pain. Remember, the HCAHPS question doesn't say, was your pain completely eliminated? They use the term controlled pain, and it's very important that patients understand that. And also, at this time, we want to discuss patients' pain expectations and seek agreement on the pain levels. Discuss how much medication could be given, and be sensitive with patients who want more medications where this could be a problem, and explain to them we're always balancing their their comfort and also their safety, and we can't give too much medication because that could be toxic. So we need to explain that. So carefully mentioning all these things could avoid an angry situation, to avoid a Shirley MacLaine meltdown situation. Now, what if, for whatever reason, we end up with an angry patient? Hopefully it's not a Shirley MacLaine meltdown patient. We don't want anything that bad, but that could be possible. You know, I've worked in healthcare 20+ years, and I've seen patients like that. If you do have an angry patient related to pain management, or this could actually works, of course, for several other issues, here are some helpful tips. The first tip is do not say calm down. That makes people even angrier. During my workshops, I always ask people, when you're angry about something, whatever it could be, when you're angry, what do you want? And usually most people say, well, I want someone to listen to me. And what happens when we say calm down, what we're really saying is keep quiet. I don't want to hear from you. Calm down, in the patient's mind, that's what it translates to. Keep quiet. I don't want to hear from you. So what happens? They become even angrier. I remember I was in a department store, and there was one man in front of me. I was waiting in line. He was very angry about something, and the salesperson told him to settle down. Well, he nearly exploded after that. So I would avoid saying calm down because it makes people extremely angry. And I also recommend start with empathy. Say something like, I know this has been a very difficult situation. I know this has been very stressful for you. I know this has been hard on you. So once again, we want to use empathy, try to see it from their perspective, because remember, empathy means being in their shoes. Being in their shoes. What are they experiencing? So we're going to temporarily slip into their shoes to see what they're experiencing. Now this next item, do not get angry yourself. Well, that sounds like a no-brainer. Of course I know I shouldn't get angry. However, in my work with hospitals for the past 20 years, I've seen a lot of healthcare professionals get very angry at angry patients, and it really makes the situation much more disastrous than it already is. There was one hospital I worked with about a year or two ago, and I was working with a physician, and we were going to see a patient who was having some anger issues. And as we were walking toward his room, a nurse was storming out of the room. And so I said to her, well, what happened in there? Oh, he's terrible. He started yelling and screaming. So I said to him, if you're not happy in this hospital, why don't you go to another hospital? Well, I almost needed medical assistance after hearing that comment. And so, of course, when we went to see him, he was just, ballistic. He was just incredibly, intensely angry. So instead of getting angry ourselves, what I recommend is whatever level the patient's talking at, we need to be a bit lower. However, we have to be careful not to go too low, because if the patient is screaming, yelling, and we go too low, from a communication standpoint, the patient may interpret that as meaning, oh, this person doesn't even care. They're talking about, they're giving a weather report. So we have to make sure our voice is up, but not too high. So speaking in a quieter voice, but not too quiet, where it seems like you're not interested, mid-level range, that will eventually help get the patient to, become resolved in whatever issue they're dealing with. And also, we want to make sure we let the patient talk. Do not interrupt until they have completely told you their story. And I'm sure we've all used a remote control for a television set. Well, there's a button that we press when we don't want any sound, and that's called the mute button. So we need to press our internal mute button to turn ourselves off for a moment so we can let the patient talk and let them hear their whole story. Now, with certain patients, this is very situational. Depending on the situation, what I will say to a patient is, what could we do to resolve this issue? And see what they say. What could we do? Now, of course, with certain situations, we can't use that, but a lot we could use that question and listen what we hear, because there was one patient, he was very angry, and no one asked him that, what could we do? And it turns out that he was angry because he had multiple specialists coming to see him, and they were not coordinating their care. So he said that in the morning, one guy came in and says, you're going to be on this medication and you're going to be discharged today. The other guy said, oh, no, you're going to be on this medication, you won't be discharged for 2 days. And then I had a third doctor come in, and he had a completely different plan, and he said, I won't be able to be discharged for several days. So I don't know who to believe, and I just wish these people would talk to each other. So obviously it was a problem with care coordination. And I asked him, what could we do to resolve it? And he says, I just want these doctors to talk to each other and not give me different information. So by asking that question, I gained a lot of very valuable information. Now, post-hospitalization, the discharge paperwork. Be sure the patient clearly understands their pain management plan before they return home. And please explain any jargon. I've seen jargon, so much jargon. Once again, jargon is one of my hot button issues, of course. So much jargon in discharge paperwork. I recently read a discharge report that said the patient had atrial fibrillation, orthostatic hypotension, and mixed hyperlipidemia, but never explained what that meant. Also, if the pain management plan, along with other medical issues, is very complicated, I recommend the teach-back method. But I don't recommend just telling the patient, okay, repeat back what I just said. Say something like, I know I've given you a lot of information here, and I want to make sure we're on the same page. So I would like you to tell me what you're going to do when you get home, and see what they say. Remember, we're not testing the patient on this. We're testing our skills at explaining things. And then we could get an idea if this is really working. Sometimes what I've said to patients, I'll say it in a friendly way, and I found this is a good way to use the teach-back method. I'll say to a patient, when you get home, and let's say your daughter asks you, well, what's your treatment plan when you get home? What will you say? And that's another way of using the teach-back in a very friendly manner. Or if a neighbor asks you, what's your treatment plan? What would you say? Once again, it's a very friendly way of getting the information to see if they're really on the same page. And we've talked about patients returning home. And when patients return home, what I recommend is a call, of course, within 24 to 48 hours to not only address their pain management needs, but also address any other needs they may have experienced at that time. That call is very critical. Once again, that's highly correlated with patient satisfaction, but we shouldn't be doing it for just the sake of patient satisfaction. We should be doing it for the sake of patient safety. Now, let's say a patient is going to a rehab center. They're going from a hospital to, say, skilled nursing facilities. When handing off the patient, even though the skilled nursing facilities will have everything on paper, I always recommend asking the receiver of the information to repeat back your instructions. Now, once again, you're probably thinking, well, it's all on paper. However, handoffs are a major source of medical errors, and we can minimize this by using the repeat back method. And what the repeat back method is, instead of saying, okay, now this person is taking this drug, this drug, this drug, this drug, this drug, and then the receiver says, okay, got it. Well, no, that's not enough. The receiver has to say, okay, I understand the patient is taking this medication, 5 milligrams twice a day. I understand they're taking this medication, XYZ. They're taking this medication, ABC, because the repeat back verifies that the receiver actually got it. For example, with family members that I was helping, I was going over the medication list with the rehab center, and of course I had permission from the family to do this, and I said, he does take, ABC drug. He does. Or this is not on the list. Oh yeah, he takes ABC drug. I've got the bottles here with me. He takes ABC drug. Oh, I wasn't aware of that. And for some reason, that just got lost along the way. And also, with medications, we could check on dosages, because with some family members, the medication was listed, but it was listed as, say, 5 milligrams once a day when it was actually 5 milligrams twice a day. So once again, to avoid handoff errors, especially with pain issues, we want to make sure that the receiver clearly gets it, because handoffs, once again, are a serious major source of medical errors. I know the Joint Commission is doing a big project on this to avoid handoff errors, and there's a lot of wonderful tools. Like I recommend you Googling SBAR if you're not familiar with, SBAR, and it's wonderful tools to ensure that we have safe and proper handoffs, because once again, this is a major source of medical errors. Next, we're going to be talking about complementary and alternative therapies. And I want to clearly distinguish between these two terms, complementary and alternative. Complementary therapies are therapies used with conventional medicine. For example, complementary therapy could be using aromatherapy to help lessen a person's discomfort after surgeries. The critical part is complementary. It's like they complement each other. The person is still undergoing conventional therapies, conventional medicine. This is something that's combined with it, as opposed to alternate therapies, alternate therapies. This is used in place of conventional medicine. And an example would be a person with cancer, instead of having chemotherapy and radiation, they decide, no, I'm going to go on this special diet, or I'm going to go to this exotic country and try their herbal remedies. That's an example of an alternative therapy, and that's what we will not be talking about today. We will be focusing strictly on complementary therapies, therapies that complement the traditional medical therapies. And let's look at some of them. Some of the therapies we could use are mind-body therapies. And these include techniques such as progressive relaxation, meditation, guided imagery, biofeedback, hypnosis. And what I recommend, a lot of the hospitals I work with will have CDs for patients that will go through guided imagery, that will go through meditation techniques, relaxation techniques. And these are just wonderful to help people deal with the pain that they're experiencing. And once again, we can't always control every bit of pain, and there might be some mild pain, mild residual pain, and this is where these mind-body therapies could come in. And notice something I have listed at the bottom of the page that I'll address right now. I say breathe with your patients. I got this idea from a physician at a recent conference, and what he says is he literally breathes with his patients. It not only relaxes the patient, it relaxes him. And one of the breathing techniques that I recommend is an inhale on the count of 4 and an exhale on the count of 6, because it's the exhale where we get the stress management benefits. So it's very important that patients practice this deep breathing. And what I recommend is it only takes a minute. Sit down with the patient, not stand, sit with them. Find a chair, sit with them, and say, I know you're feeling some anxiety here. How about if we take some deep breaths together? And it's inhale on 4, exhale on 6. So if you're feeling anxious and you're here by yourself, just do some deep breathing on your own. And just sit there with, we're going to do an inhale, 1, 2, 3, 4, and an exhale, 1, 2, 3, 4, 5, 6. So breathe with your patients. It's such a simple, easy thing to do, and once again, it's a wonderful tool. Another complementary therapy is massage therapy. This is very popular to relieve pain. It's a wonderful tool. Another, and there's some controversy about this, but certain things have been found to be helpful: dietary approaches, nutritional supplements, herbal remedies. And it's, of course, very important that we know what herbal remedies people might be taking, because some of those herbal remedies, when you're doing your intake, could interfere with traditional medications. For example, I know certain herbal remedies actually could interfere with certain chemotherapeutic agents, so it's important we know up front. But some of them have actually been found to be helpful. I've heard of certain seasonings, certain spices could actually be anti-inflammatory and help. And once again, this is something that needs to be discussed one-on-one, and there has to be some research, of course, backing this up. And acupuncture, of course, that's another tool that's been found to be very helpful. This is something more to discuss for discharge with the patient. And of course, with additional complementary therapies, there's, I know people have used music therapy, there's art therapy, there's humor therapy. I know of organizations where they'll have, they call it a humor basket. It'll be filled with all kinds of props and fun things that people could play with. There's bubbles and other toys. There's nothing wrong with being a kid again. And also some hospitals for complementary therapies, they'll have a clown's visit. Another form of complementary therapies is pet therapy, which is a wonderful, ideal therapy. Dogs are extremely therapeutic. We have a dog. My wife and I have one of our dogs is a therapy dog, and he visits patients, but the important thing is you want to find out ahead of time who wants a visit from the dog, because you don't want to just run in. Some people just aren't into dogs. I mean, I love dogs. A lot of people love dogs. We just check, in about an hour we'll be having a dog visit. Would you like a visit? And then just find out which rooms, and then we know which rooms to go to. So once again, these complementary therapies are wonderful, and I highly recommend them. Once again, they complement traditional therapies, not instead of. They complement traditional therapy. Now let's look at our program objectives again. What we've covered, we talked about methods of communicating with patients through the continuum of care. We've talked about tips to actually improve your bottom line, because the higher your scores, the higher your reimbursement. And we talked about how to avoid patients from becoming angry. We talked about handling patients when they do become angry, which of course we hopefully want to avoid. We talked about reworking the common 1 to 10 pain scale. And we also talked about the use of non-pharmaceutical methods of pain management. And in this case, we're talking about complementary therapies. Now, I just did another excellent tool that I recommend you do with patients. There's something in the communication world, the speaking training world, we have this saying: tell them what you're going to tell them, and then tell them what you told them. If something is important, we need to repeat it. Think about the commercials you see for cars or restaurants or computers or cell phones. You see them over and over again because the marketing people know that it's not just one time. You have to keep hearing it over and over and over until it sticks. But in healthcare, we say something to a patient one time and we expect them to remember it forever. Well, it doesn't work that way. If something is important, you need to hammer it in there. You need to get it into their minds, and that means repeating important things and repeating, key things, so this way it will help it come home. And keep in mind, if we're talking about hospitalized patients, we've got the added stress of being in the hospital. They're not feeling well. They're in an environment that's foreign to them, and when you add all those factors, their retention is even worse. So once again, if something is important, we need to repeat it and bring it home. Now, before we open it up for Q&A, I have my favorite communication quote here by the wonderful Dr. Stephen Covey, the author of the outstanding book. It's a classic. I think it was written over 20 years ago, but it's an absolute classic. It's timeless. The 7 Habits of Highly Effective People. And this is one of his quotes. Most people do not listen with the intent to understand. They listen with the intent to reply. So in other words, when people are talking and we're listening, what we're really doing is we're just waiting for them to finish so we could go on with our own agenda rather than really listening. So what we need to do, instead of focusing on our own agenda, just listen with the intent to understand what they're saying and help them rather than just waiting for them to finish up so we could go on with our own agenda. And before we get into the Q&A, just if you'd like to contact me, I've got my contact information up there. Got our phone number, 800-677-3256, or please feel free to visit our website, communicatingwithpatients.com. So now, in the time we have remaining, I'm going to open it up for any questions, and I'd love to answer any questions you may have.
Thank you, Edward, for that informative presentation. We will now open it up for questions. If you have our question for a speaker, please type it into the GoToWebinar questions box in the panel on the right side of your screen. While everyone's submitting questions, I want to remind you that today's webinar is sponsored by WellBe's Guided CarePath. A guided CarePath can help set proper expectations for surgery, including pain management information. It works like the signpost Edward mentioned and repeats things over time by sending email reminders and reinforcing information more than once. Smart checklists are delivered just in time as patients progress through their care plans. The information is always there for reference when needed in case preparation or follow-up instructions are forgotten. This helps reduce patient anxiety and improves outcomes. To request a free demonstration, visit us at wellbe.me. Now, we are offering a free 5-minute pain assessment tool. If you'd like a copy of that tool that goes along with this presentation, just respond to the poll on your screen. I'm going to open up the questions now. All right, Edward, our first question is, how do we encourage adherence to pain medication plans who are reluctant to take it on a scheduled basis?
Oh, okay. So we're talking about here that people are, there's a plan in place and they're resistant to that plan. And what I recommend, of course, if there's any resistance, this could be a red flag that the pre-hospitalization discussion maybe was not strong enough, because through an excellent pre-hospitalization discussion, a lot of these issues could be avoided if they don't want to take it on a regular basis. For example, there could be there could be multiple issues here. Some people are reluctant to take pain medications because they're fearful of side effects. So once again, that needs to be discussed. Is there a fear of side effects here? Some patients are fearful also of becoming dependent, even though the chances of that are very unlikely in a person that is not a drug seeker. It's very unlikely. So determine what the issues are. And of course, there's some people who just I'm going to tough it out. I'm not going to take these meds, and you want to see if that's an issue. And for people that want to tough it out, what I recommend to them is that when a person is in pain, their blood pressure is higher, their heart rate's higher, and their body is not able to get rest and is not able to heal fast enough. So it's not just a matter of toughing it out. It's a matter of letting them know that we want their body to rest, and when you're in pain, your body is not resting very well. So once again, it could be a pre-hospitalization issue, knowing what the issues are, and also mentioning what exactly is the issue, and if it's a dependency concern, if it's I'm going to get sick from the meds concern. So you need to find out what those issues are. Thank you for asking.
Great. Our next question is there any HIPAA concerns with using the whiteboard with pain med information for shared patient rooms or visitors?
Yeah, that I'm not as that I'd have to actually do a little research. So obviously, for a room that's a private, there wouldn't be an issue about that. And of course, with HIPAA, we have to be careful. We can't go in the hallway and say, the person in room 203, Bob Jones, is taking this for medication. So if it's a private room, I understand there's no HIPAA regulations. I've worked with many hospitals that use the whiteboards, and there's never been an issue with HIPAA for a private room. For a shared room, that I would actually have to do some research before I could answer that. Thank you for asking.
All right. How do I handle those patients who keep asking for more pain medication than I feel is safe?
Yeah, once again, this goes back to the pre-hospitalization information, mentioning that we're always balancing their comfort with safety, and we're doing everything possible to make them as comfortable as possible, but there might still be some residual pain, and at some point we can't give them more pain medication because this could be toxic, and we have to think about their safety while they're recovering from whatever procedure. And now the thing is, if a person's in agonizing pain, of course we have to address this. But if it's very minor pain, maybe low on the scale, a 2, that's when we could talk about we have to be careful of safety issues, and that's when we could bring up the discussion of complementary therapies, a relaxation tape. It could be maybe they need to be have a visit from a doggy. So there's complementary therapies in this case. Thanks for asking.
Right, this question's from a nurse. As a nurse, do you have any suggestions on how to advocate for a patient when a doctor does not seem to be addressing a high level of pain reported by the patient?
Yeah, once again, this is where actually the empathy comes in. Because remember, we connect with each other through empathy. So rather than saying, this patient is in a lot of pain, I want you to do something about it. This patient is in a lot of pain. Now do something. What I recommend is approaching it from an empathy standpoint, saying, this patient has been, feeling, very distressed about this, and I want this patient to feel better. And what I feel at this point would be some change in medication, a new medication. So use it from an empathy standpoint rather than a point, well, listen here, this is what I recommend. So what I recommend is using lots of empathy, explaining that your case, and use it and think of the psychosocial, because we all connect through empathy. So, and I've seen a lot of those cases backfire because the person will say, hey, this person's in pain and this is what I want you to do, and a discussion to say, I know that you have your concerns about this person, but I've been working with this person for 2 days now. I know they're experiencing some significant pain, and I would like you to consider, adding some pain medications, changing pain medications. And once again, this potentially could be an issue of a pre-hospitalization issue where all the needs were not addressed. Thank you for asking.
Our next question asks, do you have any advice for resources for evidence-based pain control guidelines, specifically the best meds, narcotics for post-op combinations?
Oh, actually, since this discussion is not directly on pain medications, it's on pain perception. There's some wonderful, I've seen some wonderful organizations that focus directly on pain management. For actually specific medications, what I recommend is actually doing a Google for pain management organizations, and they have wonderful resources for different combinations of pain meds to use. But one thing I do recommend, and once again, this is related to why it's so important to do the pre-hospitalization discussions. For some patients who have concerns about pain medication, is to talk to them about different options. What I recommend is having a variety of post-op orders. So the person will have a lot of options up front, and you don't have to go through the process, okay, well, let's try this, let's try this. So you'll have the options available up front. But once again, there's a lot of wonderful pain management organizations that would have great discussions on what medications to use and how to use them. But once again, I highly recommend these are conversations that need to be handled before they have their surgery, before they're in the hospital, to avoid any potential outburst issues. Thank you for asking.
Yeah, I might also recommend contacting your pharmacist and getting their thoughts on what they've seen working best.
Absolutely, and I recommend prevention is the key. Take care of all of these issues before the hospitalization.
Okay, our next question says, as a nurse, I hear other nurses who state that they do not continue to medicate the patient for pain when they don't ask for it because they don't appear to be in pain, or they will say, I have given them a lot of medication already.
Okay, so the question is, if a patient's not asking for it and they don't appear to be in any pain, should you stop giving them pain medication? It sounds like that's what the question is. So once again, this is where the open discussions with patients come in, because a patient might not be stating they have any pain, but they could be one of these stoic people. Oh, I'm not going to take it. I'm going to tough it out. I could handle this. I'm strong. So even though they might not be saying they're in pain, they might not appear to be in pain. I have relatives who are like this. Oh, I don't need that pain medication. I'm just going to tough it out. But we still need to have the discussions when we do our hourly rounding about asking them how their pain is. And also, sometimes I get some tips from the family members. So I'll walk in, talk to the patient. Oh, I'm fine. I'm not in any pain. He's lying. He's in terrible pain. Could you do something? I said not to say anything. No, this is why you need the pain. So that's why they might not specifically say they're in pain, but they still might be experiencing pain, and that's what we need to say. You don't have to tough it out. If you're experiencing pain, then we need to talk about it, because when you're experiencing pain, your blood pressure's higher, your heart rate's higher, and you don't heal as fast. So it's important that we have these discussions, even though they might not be mentioning this particular issue. Thanks for asking.
And maybe we have time for more. We provide our patients with educational literature discussing pain management. Do you have any unique approaches to patient education for pain management?
Yes. Now, one thing, I tell you where I got this idea from. My wife shows and breeds pugs. We go to a repo vet, and that repo vet does the best patient education that I have ever seen. What they do is they give us a brochure, they open it up, and they highlight the important things that we need to know. Then what they do is they develop what I call a one sheet. It will have a summary of all the important information, and then they highlight things. So what I recommend for patient education, don't just hand them a brochure. Quickly open it, highlight a few things, tell them this is what's primarily important, and now you've personalized it for them, and they're more likely to use it. And also what I recommend, video-based training is wonderful. The only thing that I do not recommend on video-based training is talking heads. They're very tedious, and sometimes I fall asleep while watching them myself. So instead of using a talking head, you could have a talking head, but just blend it, say, with some interesting graphics or music. Just make sure it's not a boring video. Make sure you have an interesting video. And videos are also wonderful because people love YouTube, and you could quickly put something up on YouTube, and that is also a wonderful tool to educate patients. Thank you for asking.
Great. That's all the time we have for today. If you have questions that you didn't have a chance to ask, feel free to email them to info@wellbe.me, and we'll get back to you. Watch your email tomorrow for a link to the recorded presentation and PDF slide set. Thanks, everyone. Thank you, Edward, and everyone have a great day.
It's my pleasure. Thank you. Bye.